So this model was developed, and the way that it's developed, of course, is for care and resource needs. And what it means is patient A that has no chronic diseases versus patient B that has diabetes versus patient C that has diabetes with retinopathy. Well, patient A is obviously going to cost less money to take care of than patient B. And patient C is going to cost more. And as you go up this ladder, that's kind of what this shows is if a patient has cancer, they are obviously going to have more resource needs, have more care needs than a patient that just is diabetic. So what this is saying is every patient you see, you should evaluate them for all of their diseases, regardless of if they're symptomatic or not. And you should work to identify these cancers earlier. You should work to identify diabetes and try to prevent complications from manifesting. But if a patient has peripheral vascular disease but doesn't have actual symptoms, doesn't mean you shouldn't do something about it. You should definitely educate the patient about it. You should tell them that, you have plaque buildup in your lower extremities. The blood flow right now may not be totally compromised, but it's getting there. So what that means is after dinner, instead of watching TV, maybe you go for a walk around the block. Get the blood circulating. As we know, we treat peripheral vascular disease with graded exercise. We don't have to start them on true medications, but even graded exercise is a treatment plan, and that should be enough to start treatment of this condition. Another question I get is, how is risk adjustment score calculated? Well, there's a lot of things that go into it, but it all starts with your documentation. Your documentation is the most important part of the risk adjustment calculation. What that means is you must have meat in your documentation. You must have how you're monitoring the disease, how you're evaluating the disease, how you're assessing the disease, and how you're treating it. That will lead to an HCC diagnostic code, an ICD-10. There are some disease interactions as well, and that will give a RAF score. That RAF score will then lead to a funding amount that will be paid out for the patient. And that funding amount, think of it as a escrow account. That's where the funding is built up. So that way, when a patient does get sick and end up in the hospital for a couple of days, there is funding to take care of that patient. Now, when it comes to RAF score, of course, if you are able to identify disease and keep that patient from getting very sick, ending up in the hospital, there will be a surplus that is built up in that escrow account. And that surplus then is shared between the provider and, of course, the MSO and the health plan. So the idea is to identify disease, start managing it, start preventing it from getting worse. And if you do this effectively and appropriately and identify all of the disease and truly identify the disease burden of the patient, but are able to help treat these conditions and keep them from getting worse, then there is funding that would be made available.